So we are on clinical disorders of the motor system. So disorders of the motor system can cause a number of things or a combination of the following, okay? This is how your book kind of talks about it. Obviously, the number one thing that you will see when somebody has a neurologic disorder, the most common symptom of a neurologic disorder is muscle weakness. So muscle weakness. Eventually, you'll have atrophy. If you have weakness for long enough, you'll have some atrophy. If you have really profound weakness, your atrophy is going to happen quicker. Yes, but if it's not so profound, it may be a little slower to occur. You may have abnormal muscle contractions. So the next one is muscle contraction. So you might see things like fibrillations and fasciculations, which I'll show you later, okay? So those are abnormal muscle contractions. So I should put so abnormal muscle contractions. You may have lack of muscle contraction. You may have things called co-contraction, where you try to activate one muscle, but the antagonist also gets activated, so it's hard for you to move because you can't isolate movement. So that's too much contraction. Sometimes you have too little contraction. You can't move it fast. You can't generate a contraction fast enough, okay? That kind of gets down to movement efficiency and speed down the next one there. So these two are sort of related right here. Muscle tone, you can have abnormalities in muscle tone. Either too little tone in the muscle, that's especially if it's a peripheral or a lower motor neuron problem, okay? So when you're in the periphery, you damage a peripheral nerve or the anterior horn cell in the spinal cord, anywhere along from the anterior horn cell out to the muscle or the neuromuscular junction. If you damage it, you're going to have what's called lower motor neurons problem, and you're going to have decreased tone and typically decreased reflexes. If you damage anywhere from the cerebral cortex down through the brainstem in the spinal cord, you're likely actually going to have, that's an upper motor neuron problem, okay? It's higher up in the central nervous system. That will often, more commonly, lead to increased resting muscle tone and heightened reflexes, okay? Because you kind of release the spinal cord control, and those reflexes at the spinal level no longer mediated by the higher pathways or information coming down, and they tend to go a little haywire, and they tend to bias towards a little higher tone and a little higher reflexes, okay? All of this, poor muscle tone, reflexes, all of this, and poor muscle contraction and poor strength can all lead to decreases in movement efficiency. When you do move, like if I'm a stroke patient, I try to move and I'm doing this kind of stuff, I have high tone, I have co-contraction, the efficiency is low. I'm using a lot of energy to do simple tasks, so it's not very efficient. I can't just do this nice isolated, just bring my hand to my face the way I want to, using the minimal amount of effort and muscles needed for the task. And then speed. Oftentimes these people cannot turn their muscles on very quickly, okay? Whether it's both an upper motor neuron or a lower motor neuron problem, the signal can't quite get there fast enough, so it's slower when they try to activate it. And then all of that can also, if you're talking postural muscles, muscles of the girdle, or even distal muscles in the ankle, they can have impaired postural control. If your leg is weak, your ankle's weak, or you've got spasticity in your foot, or you've got weakness in your trunk, you're going to have trouble dealing with postural control, especially challenging, soft surfaces, destabilization, or perturbations. Those are all things that are related to deficits in the motor system, okay? So regarding each of these a little more specifically, so changes in muscle strength and bulk. So strength, if you have loss of strength, it's typically called paralysis, paresis, and then bulk atrophy, okay? Paralysis is where you have complete loss of voluntary muscle contraction. The person is totally paralyzed. They have paralysis. They can't move their limb at all. I mean, try to move it. Nope, it's paralyzed. Try to move your leg. Paralysis, okay? They have no movement. Most people have some movement. Even spinal cord injury patients, many of them are incomplete and have some movement somewhere in their body or in that limb. That's, even though it's impaired or weak, it has some movement somewhere in it. That's called paresis or palegia, okay? So if you hear the term hemiplegia or hemiparesis or paraplegia or tetra is 4. So typically somebody who's tetraplegic, they're not totally paralyzed. They usually have some, even if they don't have any lower extremity function. So the lower body could have paralysis, but the upper body often has some leftover movement, unless they're like really high, like a C2, C3, and they're on a vent, then they can be completely paralyzed and have paralysis. But if they have any movement or of their limbs, it's more of a plegia. So a tetraplegia, usually they have some movement of their upper body. Okay. That's the better term than quadriparesis or quadriplegia. Okay, is tetraplegia is the term that is more correct. Although quadriplegia is used pretty interchangeably. So quadra or tetra. Okay. Then atrophy. You guys know what atrophy is. Though there's a combination typically. So initially you have the neurogenic loss. So once your muscle loses that input, and your muscles are always getting some input from your nervous system. That's why they have some resting tone. Once you lose some of that input, you start to have atrophy. And that initial atrophy that you get right away is more neurogenic in nature. Okay? But then over the course of several days to weeks and so forth, you start to transition more into just disuse, because then you've got the combination of, you got the lack of normal impulses keeping the muscle plumped up to what it normally should be, to resting state. But then you have, because you're not getting out of bed or moving, then you have the disuse atrophy. So just be aware that you can have both. And we may not be able, so I have patients who have atrophy due to stroke or multiple sclerosis. And I can, though, do strengthening with them, and I can improve their muscle bulk, but mainly from the disuse atrophy. Even if I can't improve the lesion or the signal getting to the muscles, if I actually use it in a purposeful way, I can at least ameliorate some of the disuse atrophy, even though I may not be able to take care of all the neurogenic atrophy. I may only get to muscle up to a certain point. If they can't generate strong enough signals to that muscle, eventually this may never be as big as the other side. But it may be bigger than what it is now if I can get them to do good strengthening program, because they haven't been active for the last 10 years, so. You guys know how to assess muscle strength and bulk. MMT, that's the big one. For assessing the motor system, number one is MMT, doing a really good, careful MMT. And if you do it right and do it carefully, you can even though the actual levels, the scoring of MMT sometimes isn't the most reliable, if you can get somebody in the right position, isolate the muscle, you can at least be able to determine if it's stronger or weaker than the other side, if it's normal or abnormal, and then it starts to help you postulate what's going on, what is the problem here, okay? If you've got a dynamometer, either handheld or one of like a Biodex, you can obviously get some more accurate information about muscle force. So MMT and dynamometry, even things like sit-to-stand test. That's a good lower body, more dynamic power test, like a 5-repetition sit-to-stand test or a 30-second sit-to-stand test. I love that for the lower body from more of a power standpoint. And then tape measure if you're looking at bulk. Just doing your tape measure stuff or dipping it in water for a limb volume measurement. You can measure atrophy that way. So muscle contractions was on that list too. So we're going to talk about involuntary muscle contractions. These are contractions that occur in the muscle that you're not in control of or you're not trying to have occur. So there's a different type. So you guys have all heard of muscle spasms and cramps. For some people this could be normal. If you're exerting yourself to a certain level, sometimes the nervous system can go a little wacky. And if you combine that with dehydration or electrolyte imbalance and all that kind of stuff, nobody's figured out the secret yet to cramps and muscle spasms other than what, pickle juice? Is that what you're supposed to drink now? Is like the pickle juice stuff? But spasms and cramps can also be a sign of a neurologic problem. People with stroke and MS get spasms and cramps that are more so than normal people. So it's a sudden involuntary contraction of the muscle. Cramps are severe, painful muscle spasms. So I think they're kind of interchangeable. So I'm not going to ask you to define the difference between a spasm and a cramp. So in your book or wherever I found this, cramps are a more severe, painful form of a spasm. A spasm is a little more quick, but then a cramp holds there longer. I think they're both pretty much the same, so spasms and cramps, okay? Um, fasciculations. Fasciculations are, yeah. Oh yeah, yep, for days, you know, and then it gets ischemic, which is why it causes. That's why then it's like then it reinforces. Then muscles around it start to go to spasm because now you got this ischemic pain, and it's just this kind of reinforcing thing. So you do like want to break the spasm. That's why they often do give, you know, muscle relaxers to people, or this is where, you know, dry needling or ice or some things, something to break that spasm cycle might be helpful doing that. What's pain is once you have a spasm, it's like it wants to come back right away, especially if you don't keep it at bay for a little bit of time. You guys have maybe been doing some activity, you get a spasm, or then, I mean, the next time you put that leg in that position or something like that, it wants to do it right away again unless you've kind of short-circuited that spasm and let it lay for a little while. Fasciculations are a thing, quick twitches of muscle fibers of a single motor unit. Remember what a motor unit is? That's the anterior horn cell, then all the motor fibers it goes to. Basically, a fasciculation is some rogue anterior horn cell is just going beep and firing, and sending an action potential spontaneously without you controlling it and causing its motor unit to fire. And we all get them. If you're fatigued, over-caffeinated, some of you get, you know, you get that little twitch in your leg, a little twitch in your cheek, and it's always my left eye. I get a little twitch up in my left eye. I don't think really, I can feel it, and if I really look, I can see it sometimes, but that's when I'm fatigued or stressed. That I get it happens more often during those situations. So, and there's some people who just have. I had a patient who had just fasciculations all over his body, but he had a normal nervous system. But he could just see he would just be rippling with fasciculations, and I'm like, dude, we better get you checked out. But he's like, no, he's fine. He was a young guy, he just had fasciculations, but he didn't have, you know, ALS or anything like that. So, yes. Spasms are a whole muscle, and a spasm moves the joint. If it's crossing a joint, it'll move your joint potentially. Okay, fasciculations do not move the joint. You can see it under the skin if it's surface enough. You can see the fasciculation, but they're not strong enough with a single motor unit to actually move a joint or anything like that. They might move your eyelid a little bit, but that's a little different than a joint. Okay, fasciculations can be abnormal or normal. Everybody, some point in their life will experience a fasciculation. However, people with ALS, MS, other problems with the nervous system have them more often, and they can be a sign of a neurologic disease. If you start having them all the time and they start spreading and you're having them all over your body, then you want to get them checked out. The next one is fibrillation. Oh, let me show you here a fasciculation. This is an abnormal fasciculation with a gentleman with amyotrophic lateral sclerosis, ALS. So you see the muscles contracting. Those are motor units firing, but they're not causing joint movement or anything like that. You can just see him firing under the skin. He's super thin with that very low body fat, so you can just see those fasciculations happening. So, all right. Fibrillations are a little different. Fibrillations are a brief contraction of a single motor fiber, not a motor unit, a single motor fiber. They're not visible. You can't feel them. The only way you can pick up a fibrillation is with a EMG, an oscilloscope and an EMG and a physiatrist sticking a needle in you. That's how you pick up fibrillations. Fibrillations are always abnormal. If you have fibrillations, there's something wrong with your nervous system. Doesn't necessarily mean it's always serious, but it can be, okay? It's more common. It can be caused by upper or lower motor neuron problems. It's more common and more frequent with lower motor neuron problems. This is what happens is when you start to have what we call deinnervation. When you're no longer having the normal input, we call trophic input. So all of our muscles have what we call this trophic input, which is the background normal stimulation that our anterior horn cells send signals and action potentials occasionally, and we're using our muscles occasionally. That's the trophic background input. When you lose trophic input, either at the peripheral nerve is cut or in the central nervous system, and you lose the normal impulses that keep the trophic input, that kind of keeps the muscle healthy, you lose that, it kind of doesn't know what to do. And all of a sudden, the little muscle fibers start, just individual muscle fibers will start popping off and randomly firing. They don't cause, you can't see them, but they'll just start randomly firing on their own. They don't know exactly why, but they'll just start doing that. The only way you can pick that up is with an EMG needle to see if you're having, they call it, de-innervation is what they're looking for basically. And usually it's a sign of either a muscle disease or a peripheral nerve lesion. However, some people with central, like a stroke, can have some fibrillations, but you usually don't, you haven't lost all input to the muscle, the trophic input, when you have a central nervous system lesion. It's more when you lose that peripheral nerve input. So. What's that? No, they're totally separate phenomena. So yeah, but that's a good question, good point. They cannot. And then again, on this involuntary muscle contraction, there is a group of disorders called hyperkinetic disorders, and that's we're going to talk about them tomorrow. They're mostly associated with the basal ganglia, damage to some circuitry in the basal ganglia. And the basal ganglia plays a regulatory role in motor output. If you damage part of the basal ganglia, it can cause too little movement. If you damage another part, it can cause too much movement. So these are hyperkinetic disorders. So it's confusing to differentiate these, and I'll show you a little chart that helps differentiate these. Well, let me go to here. So looking at chorea, bulismeth, and athetosis. This is a nice little thing that shows you kind of the characteristics of each. So if you look at chorea, bulismus, and athetosis going from top to bottom. So chorea, it tends to be a rapid type movement. Same with bulismus, where athetosis is more of a slow movement. All of them are involuntary, because these are involuntary muscle contractions. You're not in control of them. They're all non-stereotypical. It means they change all the time. They don't do the same move. A tremor will be stereotypical, which isn't on this list. So a tremor is generally stereotypical. It does it the same way over and over, the tremor. Where these have a lot of different kind of unique movements that are always changing, and they're not stereotypical in nature. So right now you're seeing that right now, this is the same, these are all the same, these are all the same. Right now, this is the only difference so far is athetosis is more slow in nature. Then we look down here. Chorea is semi-purposeful in nature. Because what happens is a person with chorea can sense it happening, and they try to mask it by moving in a way that makes it look semi-purposeful, because they're trying to make it not look involuntary, because they can feel this movement coming on. Then they try to ameliorate that movement so it looks semi-purposeful, because it is sort of semi-purposeful, but it comes on initially non-purposeful, but then they try to overcome it and makes it look semi-purposeful. Okay, where bulismus and athetosis are very non-purposeful in nature. Some characteristics of chorea. Chorea is more of a dance-like movement, and you'll see what we're talking about, especially when walking. They do when they walk, it's the choreic dance, and and you'll see it. And even when they're sitting, it might look like they're, almost like grooving, to the beat when they're sitting there. So, where bulismus, so it's still pretty rapid though. It's kind of a rapid movement, but it's not quite as rapid as bulismus is like. Woo, like their arm just will flail out like that, or their leg will do that. It's just this rapid. It's usually, so bulismus is usually always on one side of the body. The arm, more arm than leg, or more leg than arm, depending on the lesion location, the subthalamic nucleus. But it's usually only on one side of the body. Chorea involves all four limbs typically, or it's bilateral in nature. It might be bilateral face, bilateral arms, bilateral legs, but chorea is more bilateral in nature. Where hemibulismus, that's why it's called hemibulismus. Hemi is half, bulismus is ball. So the early people that found this looked like somebody was trying to throw a ball. They were trying to with their arm was just flinging around like they're trying to throw a ball. That's why I call it hemibulismus. Chorea is more distal in nature, where bulismus is more the proximal muscles doing that motion. Yeah. What's that? Tourette's does not fall under these categories. That's its own syndrome. So Tourette's usually has but it's usually a head movement. And so it'd be a totally separate thing, Tourette's, and it's also got usually an auditory, verbal expression component to it too. So doesn't involve basal. It's a different than basal ganglia. It's a frontal lobe kind of issue. So, and then athetosis is more of that should say writhing instead of writing. It's more of a writhing motion, but it often looks like they're writing when they're writhing. And you'll see a picture of the person that looks like they're almost, and it has a propensity to affect the upper extremity, the athetosis. So it's slower, it's writhing, and it tends to affect the upper limb. So going back here, so let's look at tremor. So tremor wasn't on that list. It's stereotypical in nature. Tremor is typically more rapid in nature. It can be proximal or distal. That's a really rapid tremor. That's one of the fastest tremors I've ever seen. This guy has Parkinson's disease. So it's stereotypical. It's only in Parkinson's. What's unique about tremor in Parkinson's disease, it's a resting tremor. As soon as they start moving, the tremor goes away. So you see how that ameliorates it when as soon as he starts moving. Then as soon as he goes back at rest, it almost looks like he's faking it, but that's not faking it. But as soon as you stop moving, yeah.
Do you feel the tremor at rest?
Yes. Oh yeah. Yeah, it really bugs them, And so a lot of times they move all the time, like Michael J. Fox, or sometimes they also have, from a side effect of the medications, they have what's called dystonia. And they get these writhing movements because it's a reaction to the medication over time. And they will purposely, constantly, put their hand in their pocket, and they'll try to do stuff that looks like they're doing semi-purposely to hide the tremor and to hide these other movements. Yes. If you purposely say, you can purposely overcome the tremor, but as soon as even when he was holding it out here, he's isometrically contracting muscles, and that makes the tremor go away. But as soon as his hands are supported, that's when the tremor comes back, and he rests that tremor.
So can you just move his fingers back and forth?
Yep, and it would go away. But it's just hard to do that all the time, so yeah.
Do they tremor while they're sleeping?
That's interesting. They do not tremor when they're sleeping. So they don't have any tremor when they're asleep. Only when they're awake and when they're truly at rest do you have the tremor. They sometimes call it a tremor in repose. It means you have to be supported. Typically you have to be sitting or lying, but awake, and then you'll get the tremor to kick in. As long as you're moving and so forth, then that's not, or sleep, then it's not.
What if you just unilaterally contract? Left hand stays resting, other one comes up. Does it quit for both?
I don't know. It's a good question. I haven't. I would think that would stay. You should. Just depend. If you're lifting a big heavy weight and you do get some crossover effect when you're lifting weight, where you start to generate some activity in the contralateral limb. If you lift a heavy enough weight or something, then it might cause enough co-contraction in the other limb to stop the tremor. But if you're just doing like a simple task, then the other one, as long as it's resting on something, then it probably is okay. It'll probably continue to do that. So. Okay. Go back here. So that was tremor. Now here's athetosis. So this is more that writhing. It's relatively slow. This is a fast, but it's like this contorting, like writhing, and it's usually the upper body that does that. Let's see what this next one is. There's another athetosis here. 15 seconds is all. Come on. Their fingers almost sometimes at rest, they'll kind of hyperextend like this, and it's more distal in nature. The writhing, you see the fingers and the thumb kind of writhing there, so that's. It can be on just one side, but there's probably times it can be both sides. You can have this with reactions to medications in Parkinson's. You can have these athetotic movements. But it's also part of chorea. Huntington's disease have both choreic movements and athetotic movements that superimpose on each other, and so sometimes they're overlapped. You can have both choreic movements and so they can have both fast and slow movements, and it's hard to separate them out because they mask each other a little bit. So this person probably has actually Huntington's disease or Huntington's chorea. So it's more common to see it in both hands. You could have a select lesion in the basal ganglia with a stroke that could cause athetosis on one side of your body. Now here's chorea. Chorea is typically going to be bilateral. This chorea often looks semi-purposeful. This is where they're like, whoa, and they feel their head go one way and they try to overcome it. You can see the trunk, the limbs are all involved, the head, the face even gets involved with these choreic movements. This is the dance-like kind of movement for sometimes, so they'll sit there and she gets up, and I don't know if she walks in this one or not, but she has. She's just reading. They have her read something, and it affects the voice obviously too. She's not showing her standing, but so that's chorea. And then here's bulismus. Remember, bulismus is generally going to be hemibulismus is what it's also just called bulismus, but most of the time it's only going to happen on one side. It's going to be a hemibulismus. His leg seems to be more involved than his arm right now. It's pretty rapid. It's kind of flinging in nature. It's rotatory in nature. So it's more like it's happening up at the hip, more proximal. He does have some distal involvement there, but there's, it's rotatory. And then so with the arm, it would be more like this. He'd be flinging it out like this. Right now, he's kind of stabilizing his hand on his knee. So that's probably reducing some of his potential arm movement there. He's trying. His is definitely affected part of the subthalamic nucleus that is connected or stereo. You have a rate when we talk about the basal ganglia. There's a portion of your subthalamic nucleus that's related to upper body, lower body. So his stroke involved mainly the part of the subthalamic nucleus associated with the lower body. The good news is these people recover really well. It's amazing. Your body adapts to that, and most people with hemibulismus have a pretty rapid recovery, and they don't have problems with it. So. Forever. Like some. Muscle tone. You guys know about muscle tone. We can have too much or too little. Too much is hypertonia. Well, let's start with too little. The first one there. Hypotonia is too little. Abnormally low resistance to passive stretch. So the way you feel this is you tell somebody, relax, give me your leg. Don't help me. And you just feel how much passive resistance you get. You have to feel a lot of, after you've done it with enough people, and you've probably done it now with your partners enough, moving limbs and telling them to relax, that you kind of have an idea there's a normal range. Some people are kind of low tone people, some people are kind of high tone, and you have to tell those high tone people to relax more and encourage them and tell them to, or try to distract them. Some people are more low tone, but there's a range of normal, okay? If you have no tone at all, where you take somebody's limb and it just flops, and oftentimes they're going to be atrophied and they're going to have no reflexes, that's when you use the term flaccid. It's a flaccid limb. The most common reason you'll see a flaccid limb is with a peripheral nerve problem, where you've actually, and it's like a big peripheral nerve problem, like they avulse their entire brachial plexus on one side and they have no motor input to the limb, or they had polio or post-polio syndrome, and all the anterior horn cells that go to the muscles of the limb, and it hangs there, and they can't move it, and it's about this big around because it atrophies so profoundly in that limb, and that's true flaccidity. Sometimes right after a spinal cord injury and right after a big stroke, your patients can initially start out with flaccidity because the nervous system is in a state that we call neuronal shock. So, but then over a course of a few days to a few weeks, they start to develop hypertonia or too much tone. But initially, when you have that big stroke, that spinal cord injury, you have no muscle tone at all sometimes. If it's a stroke, it's going to be on one side of your body. If it's a spinal cord, it's going to be your legs or your arms and legs, depending on where the level of lesion is. And they can be totally flaccid. But over a course of days and weeks, you'll start to notice some tones start to come back as the spinal cord reflexes start to figure out, what do we do now that we don't have this descending input coming into us? Yes, they would be complete paralysis. You would call that paralysis. And if they start to get some movement back, then they no longer have true paralysis. It would be more of a plegia or a paresis. But yeah, during that flaccid time, okay. Then the opposite of too little is too much, hypertonia. Abnormally high resistance to passive stretch. So you pick up the limb and you feel too much resistance even when the person is supposed to be relaxed, okay? Spastic hypertonia is when the faster you move the limb, the more resistance you encounter. It's velocity-dependent hypertonia is what spasticity is. Spasticity is velocity-dependent hypertonia. The faster I move your leg, the faster harder and faster I whack that reflex hammer on your knee, the bigger the reflex or the more tone I elicit when I try to move your limb through, because you're activating the muscle spindle. And it's going back to that hyperactive reflex center in the spinal cord and reinforcing the agonistic motor facilitation from that reflex, okay? And that's the muscle spindle will send a larger signal the faster you lengthen it, okay? So the faster you move it, the more resistance you get. That's spastic hypertonia. There's also what's called rigidity, okay? It's a velocity independent or non-velocity dependent type of tone. So this is a person with typically Parkinson's or a basal ganglia problem or a cerebellar problem. Sometimes they have slightly lower tone in cerebellum, but you lift their leg and you go, and it's hard to move, and it's often hard to move in both directions. And the faster you move it, it doesn't change the resistance. The resistance stays constant no matter how fast you try to move it. Slow, fast, it's just a constant amount of rigidity or resistance to movement. And then if you have really severe hypertonia that involves your reflexes, and you get what's called clonus, where if you do a quick stretch to a muscle, as long as you maintain that quick stretch, it keeps stretching itself essentially, because the muscle, you stretch the muscle, it beats back at you, and if you keep maintaining that, it just keeps doing. You just keep eliciting the same stretch reflex over and over again, and it doesn't. It can ameliorate after, say, a few 4-beat clonus. So we'll show you how to do clonus, and you stretch the ankle, and it beats back at you, boom, 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 and you're maintaining a stretch, and then it goes away after 4 beats. That's called a 4-beat clonus. Some people have what's called sustained clonus, where as long as you maintain that stretch, it'll just keep going. It'll keep beating back at you for the next 2 hours if you want it to. That's sustained clonus. But most people with upper motor neuron problems usually have, anywhere from a 1 to a 4 or 5 beat clonus. But then your people that have really high tone can have that sustained clonus. You can. So eventually the muscle will fatigue, but it's a pretty brief contraction and allows enough time for the muscle to kind of reset, but it can fatigue out. Eventually, I've never tried to do it more than like 2 minutes with somebody to see if it fatigues out, but eventually it probably would habituate and fatigue out, so, and change it. So damage almost anywhere in the motor system can alter muscle tone. So upper motor neuron, lower motor neuron, spinal cord, brainstem, cerebrum, peripheral nerve, anywhere along that will change muscle tone, okay? I mentioned before, with big upper motor neuron lesions, you initially have this what's called CNS shock, where the central nervous system and the nervous system doesn't know how to act. Big stroke, spinal cord injury. When it loses that normal input from higher centers, your nervous system temporarily shuts down. It says, we don't know what to do, let's just shut down. and wait to see what happens here. And then over time, your nervous system starts to say, now this is our new baseline. Let's figure out how to optimize movement and work despite the damage that occurred, okay? But that may take several days to several weeks before you see what their new tonal set, new reflex set is going to be, okay? I think we're going to take a break before I get into the next little section here on decerebrate rigidity and decorticate rigidity, because that takes into account some other bigger concepts. So, any questions before you go on break? Good questions so far. All right, come back in 10. So now we're going to just talk about these two things. One's called decerebrate rigidity and the other called decorticate rigidity. Your book mentions them. So most patients who have decerebrate rigidity, you're probably not going to be seeing in physical therapy because they are in a bad way. They're likely, you know, they're worried more about this person living or dying than you doing physical therapy on them if they're decerebrate. Decerebrate is this, when the upper limbs are extended, the lower limbs are extended, and both upper and both lower limbs are extended, and they're totally, we call decerebrate, okay? That means you have not only probably a big lesion in your cerebrum, but your brainstem is now damaged too, and particularly the midbrain, okay? Often what happens is you get a really big brain injury and you get swelling in your brain and it pushes your brainstem down into your foramen magnum, and one of the places that gets kind of smushed in between is the meeting point between the brainstem and the cerebrum is the midbrain, right? And the midbrain gets damaged. Or your head is so violently, moved or decelerated or that you twist and you compromise the connection between the cerebrum and the midbrain, and you damage all the axons and the area within the midbrain itself, okay? So, and because you have brainstem damage, you also have maybe, you also probably can compromise some of the medulla and pons, which has your respiratory and cardiac centers, and so they're struggling to keep you alive, and you're not able to probably interact with the world at this point, and you're just decerebrate. And that's, you may be called in if somebody's in decerebrate posturing for an extended period of time for positioning and some range of motion. However, sometimes I've worked with a number of patients who are decerebrate. They are so decerebrately rigid that you cannot move. I could not move their limb. I might be able to move a proximal joint a little bit, but I can't break, especially knee. I can't even break their knee tone. They're so and they can be so decerebrate that the only thing touching the bed is the back of their head, their elbows, and their heels, and they can be totally they have such trunk extension, although the bed's usually soft enough, they sink enough into it, but these people need to be positioned where they get sores on their heels, the back of their head really quickly, so you got to get them on their side, you got to put them in air bed, that kind of stuff. So that's decerebrate, which usually involves some severe midbrain lesion, either primarily or secondarily from swelling or something like that. Decorticate rigidity is a little different. Decorticate means you have a severe lesion above the midbrain. That means pretty much anywhere in the cerebrum. You will see patients who have, if you have a severe lesion of the cerebrum that involves both sides of the cerebrum, so a brain injury typically, then swelling, but it hasn't caused problems with the midbrain yet, hopefully it doesn't, you will see more of this pattern where the upper extremities are flexed, the lower body's extended, okay? This is decorticate rigidity, okay? Many of your stroke patients will display a decorticate type posturing, but only on one side because they damaged one side of their cerebrum. If you just damage one side of your cerebrum, like a big stroke, they often present like this, with one arm and one leg contralateral to where the lesion is. If they have both arms and legs are involved, then it's a big problem with both sides of their cerebrum. They usually have some head injury with swelling that's compromised the entire cerebrum, but hasn't pushed down their midbrain or compromised the midbrain at this point, okay? It's a little bit better, but it's not that much better, Somebody who has bilateral decorticate rigidity, you're probably maybe not seeing that patient very much either. However, you see a lot of stroke patients who have unilateral hemi-sided decorticate posturing or rigidity related to their stroke because they just have damage on one side of the cerebrum that's pretty big. So You can initially, yes. So yeah, you can go into that posturing when you have, boom, you get a concussion, your brain shuts down briefly, including it could involve the midbrain during that initial tweak, and they go into that posturing like that. But then it gets better. If it gets worse or doesn't change, then obviously they need to go probably have their cranium opened up and relieve the pressure or something like that. So, yep. So let's figure out this little problem here. So the top is decerebrate, and I think of decerebrate, I remember extension, because decerebrate has more E's in it. E, 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 it's got like 4 E's, so it's like extension. It got all 4 limbs are extended. That's how I remember decerebrate. Decorticate has less E's, so only has 2 E's, so the legs are extended, but the arms are flexed. That's how I remember decorticate as flexed arms, lower body extended. Okay. This is the why this happens. So remember we have, some pathways that we talked about, okay? We have several tracks that tend to bias extension normally, and they tend to work pretty normally without much influence from the cortex. All of our brainstem pathways for the motor system, and does this on the, I'll re-upload this PowerPoint with this particular slide on there. I'll because I changed 1 or 2 other slides. I'll re-upload the PowerPoint. So all of our midbrain tracks, not all of them, but most of them get some influence from higher centers. So there's some axons that go down and tell them, hey, act this way, okay? Be this active or be this non-active. They influence those medial gross activating pathways and some of the lateral activating pathways that start in the brainstem. So there are tracks that tend to bias extension in our body. I told you a lot of the medial activating pathways tend to bias extension because it keeps our body upright against gravity without having to even think about it, okay? So these 2 in particular, the pontine reticulospinal tract and the lateral vestibulospinal tract, tend to help maintain extension, and they do a pretty good job of that. They tend to function pretty normally even with minimal cortical influence, okay? They tend to do their job. They tend to do it the same whether your cortex is working or whether it's not working, okay? So those are tracks that bias extension. Then we have a couple tracks that tend to bias flexion that are starting in the brainstem. These are brainstem tracks, okay? The lateral cortical spinal also biases flexion, but we're talking about brainstem tracks right now. You have the medullary or lateral reticulospinal tract. When it's functioning so these 2 tracks that bias flexion tend to require cortical influence. You have to have a normal cortex for these to do their jobs right. So the medullary lateral reticulospinal tract, when it has cortical influence, it tends to inhibit extensors. There's too much extension when you lose cortical influence. So this track here, which tends to bias flexion, when you lose cortical influence, now it biases extension. So now it goes up with these guys. If you have a big stroke or brain injury in your cerebrum, now this guy turns into an extensor bias tract because it requires normal cortical influence to maintain its flexor bias. The rubrospinal tract's a little different. It facilitates upper extremity flexion, and it requires cortical influence to maintain the right amount of excitation or facilitation of upper extremity flexors. When you lose the cortical influence, the rubrospinal tract causes too much upper extremity flexion. It works too hard when it doesn't have the cortex telling it to stay at this certain level. Not up here, but in the middle. We want a certain amount. So when you lose that, you have too much flexion of your upper extremities. Okay? So here's how we get decorticate versus decerebrate rigidity. So let's put our red nucleus in here. We'll just worry about the rubrospinal tract. The rubrospinal tract is really the key here. And it crosses over, goes over to our upper extremities on each side. Hand. All right, and it creates upper extremity flexion, a reasonable amount of upper extremity flexion facilitation when the cortex is working normally. So the cortex has some influence over these to keep it at the right level of activity, okay? So if you have a big lesion in the cortex involving both sides, these guys, so this normally the cortex actually inhibits the cerebrospinal tract a little bit. So now you've taken away that inhibitory influence. So now the cerebrospinal tract gets overactive. And it causes too much flexion of the upper extremities. Does that make sense? You've lost that cortical influence. So that causes too much flexion. All the rest of these, so the tracts at bias extension, they don't require any influence from the cortex. They're going to just continue doing extension. But now this lateral medullary reticulospinal tract, now it also is doing extension because it lost some of its cortical influence. So you've got upper extremity flexion, then all the rest of those brainstem tracts are doing extension. So that's why you get upper extremity flexion, lower body, and trunk extension, is because that's how you've shifted the balance of these tracts, okay? That's decorticate rigidity, corticate cortex. Cortex is damaged. But now let's do this. Now let's have a lesion that extends down into the midbrain. And that lesion typically blocks even cortical influence from higher centers. When you wipe out the cerebrospinal tract, now the upper body has very little flexion bias to it. So now what you have left, let me just erase some of this. What you have left functioning is all of these tracts, the pontine, the lateral vestibular, and the medullary. And because you do lose cortical influence, because it gets blocked here at the brainstem or at the midbrain, now all you have left is all extensor bias tracts. So that's why now everything's extension at this point, because you lose the cerebrospinal influence. So the decorticate, you had too much cerebrospinal influence. Now you don't have any cerebrospinal influence, so now all you have left is extensor bias tracts. So that's why everything goes extensor at that point. Yeah. This is if you have midbrain damage. Yeah, so if you have a damage where either the midbrain is damaged, or typically what happens is you have a lot of swelling. You usually have the cerebrum and the midbrain. If you have midbrain damage, you're probably going to have cerebral damage too. So it's usually somebody with a big bleed, a big brain injury, that they get swelling and they pushes their brainstem down into the foramen magnum, then everything gets pushed together and eventually the midbrain gets squeezed in between and shuts down the cerebrospinal tract. So now you lose upper extremity flexion input from the cerebrospinal tract. Now the only thing you have left is all the rest of the tracts are functioning like extensor bias tracts. Does that make sense? Because even this medullary lateral reticular, which typically inhibits extensors, now all of a sudden it's no longer inhibiting extensors, it's allowing extensors to work or overwork, because you've lost the cortical influence plus you've lost the cerebrospinal influence. So to everything below that in the pons and the medulla, all those tracts are all extensor biased at this point. They're not affected. They just keep doing their extensor bias thing. Yeah, and we've also here we've lost the lateral cortical spinal tract typically here. If you have a midbrain lesion and if you have a cerebral lesion that's big enough, you've lost the lateral cortical spinal tract's the one that is the big flexor, and allows you to do the discrete, fractionated movements. So now all the other tracts are mostly the postural gross movement tracts are left, and they all tend to bias extension when left to their own devices. It's a default thing for our body to go with extension because that keeps us against gravity. Does that make sense? At least our more primitive postural gross movement pathways. Oops. Let that absorb in there a little bit. So, all right. So now we're going to talk about assessing muscle tone. If we have a problem with muscle tone, it's through passive range of motion, which we'll do in class here in a little bit. And then modified Ash, there's a couple different scoring systems we can use. None of them are that great. They don't have the best reliability and validity, but they're what we can use in a pinch in the clinic. The most commonly used one is the modified Ashworth scale. You should be aware of the Tardo scale as well. It's another way to measure tone passively. Both of them involve just moving the limb passively. The modified Ashworth scale typically involves moving the limb very slowly, which we'll do in class, and then superimposing a few quick stretches, or a few quick movements of the limb. The Tardo scale does 3 distinct speeds, and it gets kind of a little messy. It takes practice. You got to get good. You got to do training with the Tardo scale. You do a very slow movement. You do movement that approximates the speed of gravity as if you drop the limb through gravity. Don't ask me how you gauge the speed of gravity. I mean, you just have to imagine if I drop your arm against gravity, that's how fast I'm supposed to move your arm, is what you think, or your leg, if I drop it against gravity. Then you do a V3 or velocity 3 where you move it faster than your limb would drop against gravity. So you're doing 3 distinct speeds, and you're monitoring 2 different things. You're monitoring when you feel the catch or the resistance at each of those speeds, so the actual range of motion, so you measure with a goniometer, I felt the catch here, and measure, and then how severe the catch was, you grade that similar to the modified Ashworth scale. So this is the modified Ashworth scale. It's a 0 to 4 scale, okay, 0 to 4, but it's modified because they added this 1 plus in here. They threw this 1 plus in here. All the rest are either 0, 1, 1 plus, 2, 3, or 4. Not to be confused with reflexes or anything like that. This is where you're passively moving the limb. So a 0 is no increase in tone. That means they're normal. To me, a 0 thinks flaccid, but it's not. 0 means that they have normal tone. There's no increase in muscle tone. So if they're flaccid, you got to write flaccid. It's not 0 tone. It's 0 means normal, okay? 1 is a slight increase in muscle tone. So you lift their leg up, and we'll do this in class, up in the lab. You lift the leg up. It's manifested by a catch and release or by minimal resistance at the end of range of motion when the affected part is moved in flexion or extension. So a 1 would be you lift the limb up and you get a little tiny catch, but then it releases. Or you don't get a catch and release, but as you get towards the end of the range, you feel extra resistance. That's not capsular or muscle, it's tone, which sometimes it's, when you start doing this, you're not sure. Am I running into a capsular, muscular end feel, or is this resistance I'm feeling because of tone? That's why the validity and these are not the best, because it takes experience to do. You got to do 100 of people's legs to know what that feels like, and everybody thinks a little different. Or if somebody's weaker or stronger than lifting somebody's big leg, that can influence it. A 1 plus versus the 1 is now a slight increase in muscle tone, manifested by a catch. So you lift the leg and you get a catch. Like as you start to move it, there's like a little catch or resistance. Then it's followed by minimal resistance through the remainder, but less than half of the range of motion. So you lift it up, you start feeling resistance, but you only feel that little bit of resistance through less than half the range of motion. So, all right. Versus a number 2 is more marked increase, whatever more marked increase means, in muscle tone, but it's through most of the range of motion. Greater than half the range of motion, you're feeling this resistance. And you just have to do enough of these, and if you work in a clinic and you kind of like work with your partners or your clinicians to establish what you consider a 0, 1, 2, as long as you're consistent and do it and you're monitoring patients, then you can be effective at it. But it does take some kind of working with each other to figure out what you guys all feel is a 1 plus, a 2. Sometimes you can do some standardization in clinic. You get a patient and you say, what do you guys think this is? And you all grade it in your head and say, all right, what did you say that was? And if you're all off, then you got to like figure out why and get everybody on the same page and do some reliability study between your own partners and clinicians. A number 3 is considerable increase in muscle tone, passive movement difficult. So it's not till you get to a 3 that you're gritting your teeth a little bit, or you're grunting, or you look like you're working a little bit. When it's a 3, if you're working to move that limb, it's a 3. Okay. The other ones you feel some resistance, but you shouldn't be having to like jump on the bed, put your shoulder into it to move them. You shouldn't be having to do weird things to try to get the leg to finally, oh, okay, I got it to release. That's a 3 at least. 4 is it's in rigid flexion or extension. Like I can't even pull their arm, or I can't flex their leg at all. It's just stiff. That's a 4 for the but this one's actually much simpler than the Tardot scale. So the Tardot scale, and again I'll upload these slides. You have 3 velocities. You do it as slow as possible, so you do this really slow and just see what kind of resistance you feel, and you see where they stop moving, and you measure that range of motion. And you write in the chart, where that range of motion endpoint was. And then you also, during that slow motion, you qualify it on this 0 to 5 scale. So not only do you mark the range of motion you first encountered, or the resistance, or stop moving, then you tell about what that felt like. And these are some similar descriptions as the modified Ashworth scale. They talk about here, once you get to a 3, they talk about fatigable clonus. If you elicit clonus, it lasts less than 10 seconds, where a 4 is unfatigable clonus, like you let it go and it just keeps going, at least for a minute or 2. And then 5 is where they get the rigid joint that you can't move at all, okay? But you do a V1, a V2, and a V3. So V2 is the speed of the limb falling, segment falling. So you do the same thing, and you move the limb at that speed of gravity falling, and you see where the initial if you get an initial catch, you feel that catches, and you measure that range, but then you also document how it felt from a 0 to 5 scale, okay? So you write down the range where you felt the initial catch or resistance, and then you also write down this grading scale, the quality of the muscle reaction, which is the X. The range of motion is actually the Y. There's the Y value, but then you do the same thing as then you do a V3, which is as fast as you can move that limb. And again, you see where it caught. Did it catch earlier in the range, and did it change the amount? The scale of how much, did that really fast one might have started eliciting clonus, where the other ones didn't elicit clonus. But where in the range did the clonus get elicited? You measure that angle. So it's a little challenging. I've never done the Tardot scale in real life. So it's used for research. The APTA and for boards, they recommend you knowing about it, but not necessarily being able to demonstrate it. So, but it's out there. Okay. Reflexes. There's 2 different types of reflexes. You guys have learned about the deep tendon reflexes. That tests the integrity of the circuit between your muscle, peripheral nerve, and spinal cord. Okay? You're just testing to see, is there some problem with that circuitry? Okay? The other ones are cutaneous reflexes. Those are where you're scraping or doing something to the surface of the skin over a certain region and looking for some motor response or stereotypical response of whatever, the face, the abdominal region, the hand, the leg. Those are cutaneous reflexes. You can use both of those to help you just confirm your suppositions about what might be wrong with a patient. Okay. The Babinski reflex we'll go through. We'll show you the flexor. Flexor withdrawal is just where you tickle their foot or you touch their hand or foot and they withdraw from you. That's a flexor withdrawal response. Babinski is the scrape on the bottom of the foot. Sometimes when you try to do the Babinski, they'll get a flexor withdrawal response as well. And so it's sometimes it's hard to see if they've got a Babinski, if they've got a really strong flexor withdrawal. You have to really look at it real quick before their leg draws away from you. Then there's an abdominal where you just scrape the abdominal region. You're looking for the umbilicus to deviate towards the same side you scraped. If it doesn't move, that either means they don't have ergot sensation there, is probably the most common reason that they don't get that deviation. So in a spinal cord injury patient, if you scrape that, if they don't have sensation, they're not going to have that reflex present typically. Then there's the glabellar reflex, which clinically for us doesn't mean a lot. You tap on somebody's forehead, so you go up to them with their eyes open, and we'll do it in class, and you tap on their head, and you should blink the first few times. But if somebody keeps tapping on your head, eventually you realize, oh, this is not a threat. I don't have to keep blinking every time they tap me on the head. Some people with basal ganglia disorders, like Parkinson's, you tap them on the head, they keep blinking and it never habituates. Every time you tap, they blink. Every time, and they don't know the exact phenomena, the connections that why that occurs. But that is one way to, if you have somebody who's got really mild Parkinson's symptoms and you do a glabellar reflex, you might notice that they don't habituate to it. And that might be a reason why you say, you know what, between the glabellar reflex and between your postural reflex and your balance isn't so great and you don't swing your arms quite enough, you probably should go back and see your doctor and get checked out for something a little further. So it's in your back pocket if you ever, I've never done it in the clinic. I've never had to use the glabellar reflex on somebody, but it's fun to do to somebody. Now, grading reflexes, so we have this other scale, so don't get this confused with the modified Ashworth or the Tardot scale, but the stretch reflex, our deep tendon reflexes, is graded on a 0 to 5 plus. And you always include a plus, 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 plus. That just helps you identify this as a reflex scale versus, even though we have a 1 plus for the modified Ashworth scale. So you just got to be clear that you're talking about deep tendon reflexes. This is deep DTRs, okay? In this case, 0 in reflexes is absent. That's abnormal, okay? 0 means nothing. You have nothing going on. You should have something going on in your reflexes. You should have a reflex. Unless you just can't get it because of user error, somebody's got too big of muscles, whatever, then, you know, that's not that would be more, you know, due to user error or something like that. Hyporeflexia would be a 1 plus, slight or sluggish. Normal is a slight muscle contraction with slight joint movement. Hyperreflexia, these all between 1 and 3 can still be considered kind of in a normal range depending on the person. If all of their reflexes are 1 plus or it's symmetric and that's just the way they are and there's no reason to speculate they have a neurologic disorder, they're just low tone person. They have hyporeflexes. If they're really hyper, you know, and they're stressed out, or they're one of these people that says, every time the doctor taps on my tendon, you got to step back, watch out, then they're just probably hyperreflexive, but they're 3 plus. If you start getting clonus, where you get more than 1 beat, I've had a few rare people that gave me 2 beats that were normal. I got boom, boom. I don't have anybody who usually gives me 3 beats. 3 beats, I'm like, ooh, maybe you have something going on with your central nervous system. So anytime you have a 3-beat clonus, that usually involves, or more, that involves CNS, upper motor neuron problem, you're thinking. You may not know why yet, but you know, your patient with cervical pain who's got cervical radiculopathy has this big disc bulge. It's herniating posteriorly that's causing radicular pain, but now all of a sudden you notice they're getting hyperactive reflexes in 1 or more legs, and they're having trouble with bladder incontinence. Now we know that the spinal cord is starting to get pushed on. Time to go to the doc now. You know, I don't need to be doing traction on this guy, you know, that kind of stuff. So that's what this kind of stuff helps you with. And number 5 is very abnormal, hyperreflexive, strong muscle contraction with sustained clonus. It just keeps going on. Movement efficiency and speed, or we'll call it coordination, is another aspect of motor impairment that you'll see, typically through observation. A lot of times I can just tell the person's coordination by watching them walk into the office or watching them get in and out of their wheelchair, transfer, move in bed. You're seeing coordination deficits. We can do a few specific tests of the upper and lower body, and we'll show you those. Finger to nose, rapid alternating movement, a heel to shin movement. If you're wanting to get a little more selective and try to find some coordination deficits, we'll go through those in lab. Postural control, just seeing how they do with sitting up and standing without falling over. How well can they control their own posture? Some simple things we do. Romberg test, which we'll go through in the lab. Then we can do more formal types of scored tests like the Tinetti and the Berg. These are scored tests. Did you guys learn about those in you haven't had geriatrics yet. You're getting that next with Dr. Merriman. He'll go through some of these tests with you, and I'll go through them again in neuro, and you'll get them in general medicine as well. So these are scored tests on certain, like 14 different categories. You score them on a 0 to 4 scale, that kind of stuff. If you have some sophisticated like testing equipment like a Biodex Balance Master or a Neurocom where it's a force plate, you can put them on eyes open, eyes closed on foam, and you measure how much sway they have, or you have them lean in different directions. You can get more formalized assessment of postural control. Or something as simple as walking heel to toe, walking on their toes, walking on their heels. You know, if you do that with a Romberg, you can start to get some idea of what's going on with this patient. Romberg is simply, there's the regular Romberg and the sharpened Romberg. A regular Romberg is stand with your feet just kind of close together. Some people have them cross their arms and start with your eyes open and just see how much sway they have. If they're really impaired, they might be swaying right now. You just make their feet come a little closer together and put their arms across their chest, and all of a sudden you start seeing sway. And if you have them close their eyes and they start, really going, that's a positive Romberg sign, because most of us are very heavily visually dependent. Vision is one of our fastest, senses. It's right there. Boom. It's like it tells me, and they may be using. We all use in our visual space the lines and natural lines in our environment to know if we're swaying or not. And so, but as soon as you take vision away, now you have to rely on your vestibular system and your sensors in your feet, your proprioceptors. If you had a patient with neuropathy who can't feel their feet, if you take vision away, now they have to rely on the vestibular system, and the vestibular system is notoriously a little slow and also tends to be impaired as you get older. And now they're just like, whoa, because they have to actually get their head to move enough to know that they're swaying down with their feet and those kind of things. So that's a positive Romberg sign. Simple test of postural control. So let's talk about, this is really important concept to know. The motor system problems can be divided into 4 broad categories. If you know these 4 broad categories, then you can you can suppose where a lesion is. You're looking for these signs or clusters of symptoms. Then you're saying this person primarily has a lower motor neuron problem. This person has primarily an upper motor neuron. They probably have a cerebellar or basal ganglia, or they have a combination of these 2. So if you know these 4 broad syndromes and what symptoms you'll see in each of these syndromes, you can pretty much piece together what's going on, okay? So we're going to call them lower motor neuron, upper motor neuron, basal ganglia, and cerebellar. Some text you will read will cause call an upper motor neuron problem. They'll call it a pyramidal system problem. They call it a pyramidal system because they call the lateral cortical spinal tract the pyramidal tract, because there's these huge cells up in your motor cortex called the Bett cells, and they look like a pyramid. They're these like big pyramidal looking cells are the Bett cells, and they're up in your motor cortex. That's what they call pyramidal tract. But it's a lateral cortical spinal tract, but we're going to call it upper motor neuron problem in general. Basal ganglia is often referred to as an extrapyramidal system problem. Most often, if somebody has an extrapyramidal disorder, they're talking about a basal ganglia disorder. Because the basal ganglia does not have any direct connections to your motor neurons. So it's outside of the pyramidal system. It indirectly influences your pyramidal system, but doesn't have a direct. We'll show you tomorrow how it does. It uses the thalamus to go back and communicate with your pyramidal tract system. But so that's called extrapyramidal. It's outside of the pyramidal system or the cortical spinal tract. The cerebellar system is also extrapyramidal. The cerebellum doesn't have any direct connections with lower motor neurons, or it uses the thalamus as well to influence those. So that's also called extrapyramidal, but most books will refer to a cerebellar problem as a cerebellar problem. Occasionally you'll hear a cerebellar problem referred to as an extrapyramidal problem, but usually they reserve extrapyramidal for a basal ganglia like Parkinson's disease. It's called an extrapyramidal disease. Okay. So let's talk about lower motor neuron syndrome first, and we're going to go through the major manifestations, clinical manifestations. Lower motor neuron, anterior horn cell or its axon, all the way out to the neuromuscular junction. Damage to the anterior horn cell or its axon or the neuromuscular junction is a lower motor neuron problem. Recognize that the anterior horn cell is in the central nervous system, in the anterior horn of the spinal cord, but it's a lower motor neuron once you get to that, once you start at that cell body, and then the axon all the way out. It's called, you damage anywhere along there, that's a lower motor neuron problem. You get decreased strength, If you damage that axon or that anterior horn cell, it's not going to send signals to the muscle. You get decreased strength. If it's really profound, you like damage a whole nerve root, or going to muscles of a limb, it's going to be flaccid. It's just going to hang there because there's just no impulses getting to that muscle. You damage, that's the final common pathway to send a signal to your muscle. You damage that, it's going to be flaccid, potentially. You might see some fibrillations, especially over time. You initially damage somebody's peripheral nerve, the muscle no longer has that trophic input. It starts to get those little single motor fibers, beep, pop, pop, pop. They just don't know what to do because they don't have any more control over them, that normal trophic input. Muscle tone will be decreased. A lower motor neuron problem always causes decrease in muscle tone. When you move their limb, it'll feel less resistance to that. They'll have absent reflexes or lower reflexes. Not always absent, depends on how much of the nerve or how many axons or the anterior horn cells are damaged, but they'll typically have lower reflexes if it's involving a nerve that goes to a muscle that's involved in the reflex. There's lots of nerves that go to muscles that we can't test reflexes very well on. That still could be a lower motor neuron problem, but movement efficiency and speed. If you're weak, you're going to be impaired. You're not going to move as quickly. If the weakness is in your trunk or lower body, and especially it could be proximal or distal, then you're going to have postural control problems. And very often, like in a peripheral neuropathy, if you damage a nerve that has motor fibers in it, there's a pretty good chance you're damaging sensory fibers too. So the fact that they can't feel their legs or feel their feet would also impact postural control, but just from the motor standpoint, they're not going to have a stronger response in their ankles or their hips to, or even their arms. If they got to be able to, when you start to fall and you got to counterbalance yourself, you got a weak arm, you can't reach your arm out to counterbalance yourself very well. These are examples of lower motor neuron disorders. Guillain-Barré, demyelination of the ventral root, Guillain-Barré syndrome. Polio. Polio is the prototypical best demonstration of a lower motor neuron problem. Polio just kills anterior horn cells. Doesn't kill anything else. People with polio perfectly conscious, but it just goes and destroys anterior horn cells. So they have flaccid limbs, or they can't even breathe because it actually you have anterior horn cells and muscle cells, motor cells that go to your respiratory and your trunk and system, and so they can't breathe, and that's where the iron lung or the ventilator they're on. But we don't obviously see it in our country anymore. There's a few cases, and there's actually been a recurrence of some of polio out there in the world. We're still trying to eradicate it. But you may see some patients who you'll be graduating in a time where you'll still have some patients who have what's called post-polio syndrome. So they had polio as a child, they lived all these years, now they're an older adult, and there's these weird things that happen because they had polio as a child, they had these other anterior horn cells that try to take over for the function for the anterior horn cells that died off, but then they wear out after time. And now they have this post-polio syndrome, so they have these really large motor units, like some of the anterior horn cells that were left that still stayed alive. They grew collaterals to try to go to a bigger motor unit, but now that motor unit dies off because eventually they wear out the cell, and now then they get loss of that function again, so it's almost like getting polio again. When they hit about 65, 68, that's when it really comes on, because when you age, you lose anterior horn cells. Most of us have plenty left. We have reserves, but people with polio don't have any reserves. They lose those anterior horn cells as they age, and if it's going to a big motor unit, boom, it's gone. And all of a sudden, they're noticing increased weakness and fatigue and so forth, so that's post-polio syndrome. But it's an anterior horn cell, lower motor neuron problem. Radiculopathy, that's impinging a nerve root. A nerve root, C5, C6, L5, S1, motor fibers in there, peripheral nerve problem, lower motor neuron, Lack of reflexes, decreased strength. Peripheral neuropathy, usually distal to proximal, same thing. You're just damaging motor nerves, axons distally, And oftentimes sensory at the same time. I'm just going to let me see if this goes to the right video or not. Here's a common gait you'll see with neuropathy. Look at his feet. His left leg is worse than his right leg. That was quick. Let's replay. It's called a steppage gait. And what you'll see is they do this. These are the characteristics of a neuropathic or steppage gait. They have increased hip and knee flexion, and usually it's because their toes they've got drop foot. The muscles in their anterior tib are weak. They have drop foot, so that they have to take in order to clear their foot, because they can't bring their toes up, they have to take increased hip and knee flexion. And they often will, when they hit the ground, you'll hear a foot slap too, because they might be able to lift their toes up a little bit, but when they hit the ground, they can't tolerate the eccentric contraction and lower their foot to the ground in a controlled way, so the foot slaps. So it's a steppage gait, often with a foot slap. So it's like, and they're just walking like this. And oftentimes they hit the ground hard, also because they can't feel their feet. And by hitting the ground hard, they send that shock wave up to their hip and knee so they can feel the ground. That's the other thing. But they also tend to hyperextend their knee because if they have really bad peripheral neuropathy and their quads are weak, they're afraid their knee's going to collapse. So the way you bias that against your knee collapsing is lock it out using the locking mechanism of the knee. So they slam the leg down, hyperextend the knee, and lock it out, but they have this kind of steppage gait. Okay, so that's a neuropathy gait. And I watch people walk around, and I have a neighbor right now watching him slowly get worse and worse with his neuropathy, and I really want to go, say, dude, you know you have neuropathy, right? Or you're seeing anybody with this, because you need AFOs pretty soon, and I could get you, I could help you with that. But I hate this neighbor. He's I should help him, and I will reach out at some point. But man, he's the hardest person in the world to help because he's just such a jerk. So some of the stuff he did to my kids, and it was crazy. All right. Upper motor neuron syndrome. Upper motor neuron, clinical manifestations are a little different. So muscle strength and bulk, decreased but not as severe as lower motor neuron. Because they usually you haven't wiped out everything. Usually you've damaged some of the track in the cerebrum, brainstem, or spinal cord, but they often have some ability to move the limb. You haven't damaged that final common pathway. You still have the lower motor neuron. You still have the reflexes that can happen that keep the muscle bulk a little bit more. You get some atrophy, but it's not as profound. They're not truly flaccid. Maybe unless they have that initial spinal shock or initial neural shock, okay? They may have fibrillations. They may have spasms. They may have cramps. They have increased tone and spasticity eventually. After the initial injury, it might take a week or two. Then they have increased tone and spasticity. SCI is a little unique. We're not going to get into that now. Sometimes they will have decreased tone but very high spasticity just because of the nature of, especially if it's a complete injury. They will often have clonus, where you get that beating back, especially in the ankle. Reflexes will typically be increased. And they often demonstrate some of those abnormal cutaneous reflexes, the Babinski reflex. We'll talk about a pronator drift, and a Hoffman reflex we'll show you. That'll also confirm upper motor neuron problem, okay? Primitive reflexes they might display too, like they might have a asymmetrical tonic neck reflex. Did you guys learn that yet? So they turn their head to the side. I have a stroke patient or something, and I'm trying to get them to extend their limb. It's like sitting like this. The only way I can get them to extend their limb is turn their head to the left. Now that helps extension, because that's a primitive reflex now that is actually, it helps me move their limb, but it's abnormal for that. That shouldn't, after a certain age, you shouldn't have a strong ATNR. You should be able to turn your head anyway and have your limbs still move normally. You shouldn't have to, so. Or you might scare them and they do this and they have a big strong Moro reflex and they eject themselves from the wheelchair or something like that. That's usually an upper motor neuron type thing. They're going to have impaired movement efficiency, they have abnormal timing, co-contraction, they can't fractionate movement. They're doing synergistic movement a lot of times where their limbs move in this very synergistic way, because especially if it's a cortex problem, where a lot of these people have a cortex problem, now they're more dominated by postural and gross movement, by those brainstem pathways, which tend to bias lower body extension and upper body flexion is what they tend to bias. So somebody with a stroke, they'll walk like this. lower body extension, because this is a stroke on my left side. My right lower body, because of my brainstem tracts that no longer getting good cortical influence, they tend to bias extension of the lower body, and the rubrospinal tract left to its own, and now doesn't have cortical influence, have too much upper extremity flexion. But that makes it hard for me now to extend my arm or move it in a fractionated way. It makes it hard for me to flex my leg in a good, easy way, in any way I want to. So those are things you'll see. Postural control will be impaired too. If somebody's got a stiff leg and an arm like this and they're spastic, they're going to have trouble with postural control. We'll show you this. Well, here's a physical therapist actually showing a Babinski sign in a patient. This is an orthotherapist who's got a patient with MS, and they're showing, he shows two reflexes. I wish the sound would work, but it's not. She's saying she has MS, a mild case. This is the Hoffman sign. You hold the IP and just get the DIP and you flick it. Looking for the thumb and index finger. Normally they wouldn't do anything. With the reflex, they come together like this, slightly. They approximate each other. That's an upper motor neuron problem in the upper extremity. Now, that's a pretty strong Babinski reflex. See that big great toe extension there? He didn't push real hard with that either. So if you have a patient who comes into your ortho clinic who's complaining of low back pain, and you notice, like, as you're testing reflexes, they're hyperreflexive and it's asymmetrical. I'm like, ooh, this is weird. And they're a female in their mid-30s or early 40s who's having new symptoms, and then you scrape the bottom of their foot and they have a positive Babinski on one side, then you're going, this person's got an upper motor neuron problem. This is not a back pain problem. This is MS, or this is a spinal cord tumor, or something, or they got a central lesion, or something like that, that's telling you that this is not just your garden variety. Back problems that are your garden variety should cause lower motor neuron problems, because normally the disc bulges to laterally and hits the nerve root and causes lower motor neuron radicular type symptoms. But you can have an upper motor neuron problem and still feel like you have pain in your limb, or you can have both. You can have radicular symptoms from a lower motor neuron problem, but the disc can be so big, or it's a tumor in there, it starts to grow in, it starts to compress on the actual spinal cord itself, not just the nerve root. Okay? Abnormal timing and muscle activation. You have trouble with initiation of movement, rate of force development. Muscle contraction time can be prolonged. They can have problems with activation of agonist-antagonist. They can't turn one muscle on, the agonist-antagonist, quickly. They'll turn on the elbow extensors, but then their elbow flexors are like fighting it. And then if you want to reverse directions, they can't turn the elbow extensors off quickly while activating the elbow flexor. So it's like they can't do things quickly between changing directions. So common terms used to describe impairments associated with upper motor neuron problems here is this thing called co-contraction. Okay? So there's a term called co-contraction where they have temporal overlap of agonist-antagonist. So they turn on triceps, but biceps won't relax quite fast enough, so there's a temporal overlap. Then when they get to the end and they try to turn on tricep doesn't turn off fast enough, so there's a temporal overlap between the two, and it makes your movement look labored and slow. Okay? Co-contraction is normal under certain circumstances, especially if we're in weight-bearing positions. If you're in closed chain positions and you're doing push-ups or you're doing things that require stabilization, you want co-contraction. But if you're doing open chain movements that are rapid in nature, you don't want a lot of co-contraction going on, especially in the distal parts of your limbs. Let's talk briefly about contracture. Most of your patients with upper motor neuron problems or motor problems in general, because they're not moving their joints through normal range, and they often end up with contracture, both at the muscle and the joint. Okay, so you get adaptive shortening of muscle. If it's long term, you actually get loss of sarcomeres. You lose some of your muscle cells. you get increase in cross-linking between the muscle fibers, so the muscle fibers kind of start sticking to each other, okay? Contracture is part of this bigger phenomena that we see in neurologic patients called myoplastic hyperstiffness. So which I think is that next? So this concept of myoplastic hyperstiffness is excessive resistance to muscle stretch due to the structural changes within a muscle due to changes in neuromuscular activity. So when you have loss of normal neural control to a muscle, especially in upper motor neuron problems, you get this myoplastic hyperstiffness over the course of several weeks to months, okay? Which involves contracture. So you actually lose sarcomeres, which takes a little while. It takes a few weeks to a few months to start losing your sarcomeres. But then the sarcomeres that remain, the muscle fibers that remain, you get this, because the muscle gets shortened, you get more overlap of the actin and myosin fibers. And over time, if you're not moving your muscle and stretching and opening up those actin and myosin fibers and getting them to slide against each other, over each other, they start sticking to each other. They get a little sticky. And so even when you try to move a muscle through the range it has available to it, it's still kind of resisted because there's sticky actin-myosin overlap. You also get selective atrophy of type 2 muscle fibers, fast twitch muscle fibers. So that's a reason why your people with upper motor neuron problems, after they've been deconditioned for a while, had the symptoms for a while, they can't move quickly. It's another reason, because they don't have fast twitch muscle fibers. They have slow twitch, but they don't have fast twitch muscle fibers. So they have trouble producing power. That's why they have trouble reacting to, like, take a quick step if they get knocked off, other than, they have their tone and those kind of things, but they actually have loss of type 2 muscle fibers. This is very common in stroke, brain injury, any big upper motor neuron lesion that causes significant weakness of the limb with tone and spasticity, okay? You also get this component of myoplastic hyperstiffness. And so this is where, like, when you're feeling a limb, if you move a limb, you might get that initial catch, especially if you move it fast. That's the reflex or the spasticity. Then you start feeling the resistance of the limb. And if the person's had a stroke for more than a few weeks, now you're encountering the myoplastic hyperstiffness. If you feel resistance now through the rest of the range. There's also the tone component. So there's some excessive neural activation going on, but it's really hard to determine what is the tone, the resting tone, versus the myoplastic hyperstiffness, which eventually they're all kind of overlap each other after the first few weeks. But range of motion activity, doing exercise through full range of motion with your patients, can help with this myoplastic hyperstiffness. I might not be able to fix the tone issue, but I can probably help reduce some of the myoplastic hyperstiffness if I'm really focused on doing activities that take their joints through full range, make the muscles work as effectively as possible, whether I get them on a recumbent stepper, a recumbent bike, doing functional activities, doing functional strength training activities that take them through the range to keep that limb from getting stiff, reducing that weak actin-myosin bonding, doing some plyometric exercise. I'm starting to do plyometrics with my stroke patients. As long as you've got a harness, or as long as you set up a safe environment, put them in a corner, you should be doing some, we're starting to work on jumping with your stroke patients. Get them on a total gym and have them do push-offs and those kind of things, and really challenge that limb to work quickly. Even if you've elicited some clonus or a little spasticity, we used to think, oh, don't do that. Like, oh my God, you're going to cause them to have more and more tone, and we found that's not true. It actually, they gain more control of their limb by doing aggressive strength training, even if we occasionally elicit some of the clonus or tone. So really more of a sports medicine approach is what neuro is becoming. The same stuff that works for, task-specific, aggressive, progressive activity, challenging the patient maximally is what you want to do. Muscle overactivity, this is the muscle contraction that is too excessive for the task. So they send the signals down, and sometimes there's too much signal, okay? And this is where they send signals to also sometimes the agonist and antagonist. So they send signals, and there's this co-contraction, maybe due to lack of skill performance. So if they're trying to stay upright and they're stressed and they're afraid they're going to fall over, and you ask them to do a movement of the arm, they may activate too many muscles as opposed to just the muscles you want to activate, okay? Because now they've lost postural control and those kind of things. So that's called muscle overactivity. And even normal people can have muscle overactivity, especially when you're learning a new task. You can use too much muscle output or muscle, especially, or you're stressed and those kind of things. Muscle tone, we've already mentioned. We can use, the modified Ashworth or the Tardot scale to assess muscle tone. It's the resting tension in a muscle, the amount of tension in a resting muscle. Examined passively, not velocity dependent. So tone is the resting, moving the limb slowly. Spasticity is the velocity dependent. That's when you're moving the limb quickly, and the faster you move it, the higher it gets. This tone, you move the limb slowly, and it shouldn't change much throughout the motion. Okay? Upper motor neurons tend to have what's called spastic hypertonia. You lift the limb up, it's a little stiff, especially stiff when you first move it. It may loosen up a little bit. It may be stiff again at the end range, but if I move it really fast, it really catches and it bites back at me. That's upper motor neuron hypertonia, spastic hypertonia. It's a combination of spasticity and hypertonia. Basal ganglia, rigid hypertonia, you lift the limb up, you move it slow, it feels stiff, and it's stiff the whole way through, and it's stiff in both directions. Spastic hypertonia tends to be stiff more in one direction than the other, depending on the patient. But the faster you move it, it doesn't change. It doesn't cause increased catch. That rigidity the amount of resistance you feel is the same whether you move it fast or slow. That's rigid hypertonia. That's basal ganglia, Parkinson's. Paresis, partial loss of movement. Occasional paralysis with complete spinal cord lesions. If it's a complete spinal cord lesion, you can truly have paralysis, or sometimes a certain post-polio or polio syndrome can have complete paralysis of an individual limb. Most people with incomplete spinal cord, stroke, MS, brain injury have some movement in their limbs. It may not be that purposeful, it may have trouble at, but then they have paresis, not true paralysis. We've already talked about spasticity and hyperreflexia, velocity dependent. Clonus is that where you repeated stretch, contractions. Examples of upper motor neuron disorders, these are your most common: spinal cord injury, stroke, brain injury, cerebral palsy is upper motor neuron, and like MS. We will go over tomorrow is cerebellum and basal ganglia. So we still haven't covered cerebellar or basal ganglia disorders as part of those, but that's what we'll cover tomorrow is the cerebellar and basal ganglia. So today we just mainly focused on upper motor neuron versus lower motor neuron disorders and those 4 broad categories. Tomorrow we'll hit cerebellar and basal ganglia disorders. Okay? Questions before we move into the lab? Do a little lab work. And I handed out a little handout for the lab today. So, okay, take 10 minutes to make your way over to the lab. We'll start at right around 11:30 and just do about 15, 20 minutes worth of lab work.